Thank
On my
you.
end, it's like one button because I'm already host. So
Okay.
it's easy. You good?
Okay. Yeah, we're good. Thank you.
All right, yeah, I'll mute.
So you're the fellowship director. Okay. Good morning, everybody. We're going to talk about care of the diabetic athlete this morning. There's a lot of points on here that are heavy on the CAQ. Usually they hit on some nutrition topics with diabetes. So we'll talk about how exercise affects those with diabetes and then some of the complications that diabetic athletes come into contact with. So there's a big population of diabetes throughout the nation, and it's growing because of our obesity epidemic. So diabetes type 2 is definitely rampant through the population, and we'll see how that decreases with the introduction of GLP-1 medication. However, with relation to our athletic population, just knowing that exercise is important in regulating blood glucose levels, and that that's the main point of studying this through for your CEQ and for counseling our athletes. So there's hyperglycemia for those with diabetes because of decreased either insulin secretion, and that's mainly for type 1 diabetics, and then insulin sensitivity for type 2 diabetics. But then there's a combination of those with end stage disease. The goal is to maintain glucose levels between 70 and 100, and a lot of times asking specifically about what levels are safe to participate, what levels are contraindicated to participate, or what you need to commit to memory. So just a slide on reviewing the pathophysiology of diabetes. So mainly those with type 1 have decreased secretion and production, episodes of hyperglycemia and weight loss at onset of diagnosis. They might present in ketoacidosis, and if this is not identified quickly, it can be fatal. So most of those who are diagnosed with type 1 are diagnosed either during their um, childhood or young adult life. It's thought to be autoimmune regulation, and a lot of well-fed athletes have been successful in managing type 1 diabetes with frequent glucose monitoring. For those with type 2, there's decreased secretion and decreased activity, decreased uptake throughout the tissues. Most patients will present either with the development of obesity or into adulthood with sedentary lifestyle. And so a lot of these athletes may present with like a larger body habitus, more muscular mass, or just more adipose tissue on board. Usually those bigger athletes who are rugby players, linemen, or might be in baseball. So physical activity is beneficial for both those with type 1 and type 2. Not only with increasing fitness, but also in decreasing necessity for reliance on insulin and maintaining better glucose values. There's a lot of improvement with social and emotional well-being as well. So goals for the athlete and the physician may differ, and so trying to come to a consensus on how to support the athlete is important. So athletes definitely benefit from the environment of having teammates and competition goals and achieving. There may be scholarship endorsement for those in school or professional benefit for financial gain. So making sure that we're able to keep these people active is important, and then making sure that the athlete can be held accountability or accountable, and making teammates and coaches aware for someone to help maintain treatment and just kind of look for symptoms as needed is also important. So as physicians, we want to prevent hypoglycemic episodes, and then end stage complications like renal failure, blindness, and peripheral vascular disease, peripheral neuropathy. So sometimes on board questions, they'll ask about athletes who may have these types of complications. And a lot of the history of diabetes is kind of an distraction. You want to focus on making sure that these end-stage complications have been monitored and are being addressed before you clear athletes to participate. And they may be prevented from participating in all sports, given if they have end-stage like renal failure or blindness, things like that. That's going to be a contraindication to participate in certain sports. Overall, the diabetic care plan is to manage glucose values within the target range to allow exercise and competition and prevent episodes of hypoglycemia, which typically happen either because of too much exogenous insulin or not enough carbohydrate replacement during or after exercise, and then prevent episodes of hyperglycemia and ketosis, and that might be because of either inaccurate delivery of insulin or over exercising muscles where insulin is injected. Recognizing signs and symptoms acutely in order to prevent complications and to address the treatment plan in 3 steps is important. And then just to maintain glycemic control. So when counseling athletes, knowing what type of diet they're following is important, knowing how nutritional supplements may affect their health. And then also there's, different athletes who may have a different outlook on how to manage their diabetes depending on what type of sport they're in or what type of physique they're targeting. So insulin can decrease the body's ability to maintain weight, and so there might be a different perception for those who have body dysmorphia or who are trying to obtain like a thinner body habitus. And so looking for those types of behaviors and desires is important in order to counsel athletes from preventing poor bone density or weight loss. Those who are in sports that require athletes to meet a certain weight target also may use insulin in order to maintain their body weight within a certain goal or certain target. So counseling these athletes on how to maintain healthy glucose values is important, and then making sure that they're using their insulin and carbohydrate replacement correctly in order to maintain those glucose values and not to expedite weight loss is important. A lot of diabetic management is unfortunately learned by trial and error. A lot of personal experiences help the athlete to know when to administer insulin or when to administer carbohydrate replacement. And so a lot of that is done just by frequent monitoring of blood glucose levels and then having values that come out of the target range or symptoms that present that then affect the athlete poorly. There are guidelines, and we'll go over some of those guidelines, but a lot of athletes use trial and error in order to make a plan as to how to maintain their glucose levels accurately. So exercise does improve insulin effects. So those who participate in exercise will then have increased glucose uptake to the muscle, which then affects glucose values. There's glucose release from liver and muscle as well. And then there's fatty acid metabolization. So there's improved insulin sensitivity with exercise, and this can last for up to 48 hours. So when athletes are exercising, they need to make sure that they are monitoring their glucose values so that they can see a trend as to how their exercise affects their glucose, and then adjust insulin delivery and carbohydrate replacement respectively. So with moderate aerobic activity, there will be increased hypoglycemia, and then with anaerobic bursts of activity, there's increased blood glucose So typically trying to balance aerobic and anaerobic activity does help to maintain glucose values within a target range. When you have extremes of either of these, you'll have the secondary changes in glucose values. So counseling athletes on how to train is important. For those without diabetes, we're able to maintain glucose levels within a normal range. Those who have diabetes 2 and obesity have impaired glucose transport. And then those who are insulin dependent are more likely to have hyperglycemia initially and then hypoglycemia after exercise if they're not administering insulin correctly and then replenishing with carbohydrate. So, counseling athletes and knowing how much carbohydrate to ingest before, during, and after activity is important. This is something that sometimes we'll present, so this is probably a slide you should commit to memory. For the overall view, just knowing that having carbohydrate replacement before activity will help to prevent hypoglycemic episodes immediately after exercise. And then for the ultra distance or the endurance athletes to prevent hypoglycemic episodes during exercise is important. Those who are engaged for longer than 60 minutes need to be ingesting carbohydrate replacement during activity. And then there's a post exercise golden recovery period where carbohydrate should be ingested in order to prevent that hypoglycemic rebound that can occur up to 48 hours after exercise. Typically, carbohydrate replacement should be targeted according to body mass. So sometimes they'll ask how much carbohydrate per kilogram. So it's 1 to 1.5 grams per kilogram. And then during this, the athlete needs to be checking blood glucose values to see how they respond to not only the exercise they did, but then also how they responded to carbohydrate replacement afterwards. There's definitely some charts to look at for exchanges and how much replenishment is needed based on, again, that balance of aerobic and anaerobic activity. For monitoring during exercise with initial training changes, glucose values should be checked pretty frequently. So we recommend typically every 30 minutes before, at least to see some type of trend that's established, and then during every 30 minutes, and then post activity every 2 hours. And that's again just to look at trends. There's now glucose monitors that athletes can wear, which can instantaneously track their values, and then also subcutaneous glucose devices that can, insulin devices that can replace. But then there's certain sports where athletes can't wear these devices, so we'll go over that as well. So this is another slide to maintain for your studies, asking that a lot of times they'll ask specific questions where an athlete presents with glucose values and they want to know is it safe for the athlete to participate. So the ideal glucose values is 70 to 150, and there's no restrictions for participation with that value. But then when values are not within that range, you need to know whether or not the athlete needs to either supplement with carbohydrates or take some time and then recheck, or if their exercise is contraindicated. So obviously, if there's any ketosis, exercise should not be present. But if they have elevated values over 300 without ketosis, then you can advise that they exercise with caution, which again just means to recheck values more frequently. If their values before exercise are less than 100, then you should recommend carbohydrate supplementation and then recheck to see that those values recover, and then the athlete can exercise again. Other things that will affect glucose values are, exogenous factors such as stress or hydration levels. So they may present with someone who's exercising in like a hot and humid condition or at altitude or already has dehydration because of other comorbidities or recent illness or things like that. So that's also going to affect glucose management and glucose values and insulin response. Hydration guidelines are also important to consider. So again, hydrating before, during, and after exercise is important. And if the athlete is already either dehydrated or is in an environment that's going to increase dehydration, then they're going to be more likely to have changing glucose values and need carbohydrate replenishment and frequent blood glucose monitoring. When athletes need carbohydrate replacement, there are other liquids to recommend over water. So your carbohydrate drinks, and then just like something else that's readily available, like milk or juice. Caffeine can cause more likelihood to lead to dehydration. And then there's carbonation that can cause some GI upset with vomiting or diarrhea. So just some of the things to kind of think about as well. When there is hypoglycemic event, knowing how to recognize that acutely and how to treat that acutely is important. This more commonly happens with diabetics with type 1 diabetes and more likely due to not supplying enough calories or enough carbohydrates before activity and then participating in activity that is in excess of what the athlete anticipated. It also can occur because of injecting insulin at an exercising muscle. So they might give a stem with like a runner who injects at their quad muscle or something of that nature. There can also be overdose or excessive exogenous insulin administration, and then that causes hypoglycemia as well. So just some other things to kind of think about. Initial signs are typically those of like the sympathetic nervous system because of epinephrine response. So hunger, anxiety, sweating, tremor, tachycardia. And then late onset will involve those like mental status changes, confusion, impaired performance or impaired speech. So sometimes, like if they're giving you a stem with someone who's participating in like a altitude or in a humid environment, but they also have diabetes, they may ask you like if someone is more likely to have if you need to evaluate glucose values, or if you think they may have like altitude sickness, or if it might be like heat related illness. And so, trying to just kind of tease through those types of things in order to identify, what the correct response is important. Before these, obviously, you always want to hydrate your athlete, check glucose values to make sure that if they need immediate carbohydrate replacement, you have that available for them. In order to prevent hypoglycemia, there's a 3-point approach. We've talked about frequent blood glucose monitoring and carbohydrate supplementation and insulin adjustment. So those are the 3 points of treatment for hypoglycemia. Teaching proper injection is important, and then rotating injection sites is also important in order to reliably deliver insulin to the body. Again, exercising muscles can expedite that release of insulin, and so then the athlete would be more likely to have hypoglycemia during exercise. And then we talked about weather considerations as well. So in managing hypoglycemia, identifying those signs and symptoms is important. You want to remove the athlete from play and then check their glucose values. If they are below 70 for glucose, then you want to administer fast-acting carbohydrates. They may give you someone who has like slurred speech or is like late to respond, or maybe has some type of mental status change. For that, you don't want to do an oral replacement. You want to do instead like a dextrose ampule. but those who are maintaining correctly, you can first administer something quickly orally. And there's some options here that are listed, and then you recheck within 15 minutes. And again, you're looking to see if there's a response from that initial carbohydrate replacement. If there hasn't been, then you would repeat the oral administration and then check again. After you've done a quick release of, or quick simple sugar release, then you also want to add on a complex carbohydrate. So something that is going to be a little bit more sustaining before the athlete returns to play. And then there can be, like if you administer too much carbohydrate, then they can have a hyperglycemic response. So again, that frequent monitoring helps you to target correct response. So again, for those who have any type of mental status change, you're going to activate your emergency response system. For those who are in the pediatric age group, we use their weight to help determine how much to replace. And then adult body size, we just use 1 amp for 25 grams of glucose in D5W. Other things to consider are delayed hypoglycemia. So this happens after exercise has completed and usually a few, like 6 to 12 hours after exercise. So for this, adolescents or college athletes, individuals who live by themselves, you want to make sure that someone else is aware that they have diabetes and is able to help monitor any symptoms and help to identify if they're having any of these type of complications quickly, because this can be fatal. Typically, for those that have like exercise either like in midday or later and haven't performed carbohydrate replacement properly, they then can have hypoglycemia during the nighttime. And if they're not able to either identify or report that they're having symptoms, then this can lead to complications like seizures and cardiac arrhythmia. Typically what happens is that, again, the athlete isn't aware of the demands of exercise and doesn't perform enough carbohydrate replacement, that then the glucose values deplete and leads to hypoglycemic events. So there's this golden replenishment period where we're supposed to encourage athletes to replenish within 2 hours of their exercise in order to prevent these hypoglycemic episodes from occurring. And then during that, to monitor glucose values to look for trends of achieved glucose. Delayed ingestion can also happen where the athlete doesn't replenish immediately after exercise or within that 2-hour time frame, and then they've already dipped into hypoglycemic values and need to kind of catch up in order to prevent further hypoglycemia. Again, assistance from another person is helpful. Knowing, that other teammates or coaches are aware is important for when they're traveling or in newer environments and need, just someone to kind of keep an eye on them as well. So ideally, balancing aerobic and anaerobic activities can help to prevent hypoglycemic episodes from occurring. Anaerobic activity typically is more short distance, sprinting type of activities, and this can allow for there to be delayed onset of hypoglycemia and have some increased glucose values, so some hyperglycemic response that then balances out the hypoglycemia. For endurance athletes, these individuals can be at increased risk for hypoglycemic episodes. They want to make sure that they decrease the basal rate of insulin administration, or if they're wearing a continuous subcutaneous insulin delivery device, that they're decreasing insulin delivery and then ingesting carbohydrates during exercise in order to ideally maintain that blood glucose value of 130 to 150. When there's increased exercise demand, carbohydrate replacement should be increased, and then exogenous insulin should be decreased. Those who exercise in the morning have a diurnal cortisol growth hormone response, and so that then requires a change in insulin administration as well. Um, and then those who we've talked about a little bit, that those who have dehydration are more likely to have complications with potential ketoacidosis. So just knowing that there's a combination of long-acting, short-acting, and rapid-acting insulin, and balancing between administration of these can help to keep glucose values within target range. Occasionally they may ask, like if there's an athlete that presents with certain values and took a specific type of insulin, which insulin may have contributed to their resulting values. So knowing like which ones should be, which ones may affect the athlete and what time frame is important. Those with type 2 diabetes are less likely to have hypoglycemic episodes. However, they still can have them. Usually, they are less reliant on exogenous insulin and more need medications to help with insulin sensitivity at the tissue level. However, when there's progressive diabetes, they may require exogenous insulin because of decreased endogenous secretion. So these athletes may also need insulin exogenously as well as sensitizers. So for travel, athletes need to carry their medication information, an ID bracelet, so that if anything happens, those on the sidelines are able to identify that they're at increased risk for these types of episodes. Management plans should be obtained or present as well, so that those who are helping to care for athletes are able to respond quickly. Athletes participating in altitude have changes with their diabetic presentation, their glycemic control, and how they then need to adjust their insulin delivery. So there's increased sympathetic tone and increased glucose production, which increases insulin resistance and may decrease their appetite. So for this, they're more likely to have changes that are different from when they participate at sea level or in their home environment, and changing their glucose or changing their insulin delivery is important in order to prevent these episodes from occurring. Those who climb in freezing weathers need to keep the insulin close to them so that the insulin is still functioning and able to treat glucose values. Scuba diving, for the most part, is contraindicated for or highly discouraged for athletes with type 1 diabetes. There's limitations where athletes can't wear continuous glucose monitors or subcutaneous insulin delivery devices. They need to make sure that there's partners aware. So in scuba medicine, you should always, swim with a partner and have communication with your partner, and maintain like visual contact so that you can communicate through hand signals. But obviously, if someone's having any type of symptoms, it's hard for them to communicate to their partner. Some of the devices are water resistant or waterproof up to a pretty shallow depth of 12 feet. And then those who do participate need to make sure that they're coming up to the surface to monitor their glucose values. So that limits how long they can dive to 30 to 45 minutes. For collision sports, athletes aren't able to wear their devices for continuous monitoring or insulin delivery. Mainly because it can be harmful, but also the equipment can break and then values aren't reliable. So physicians can provide letters to support use of equipment, and there can be exceptions given, but then those that aren't wearing their devices need to increase their monitoring and replacement. Sports like softball and baseball are ideal for athletes with diabetes because there's a combination of aerobic and anaerobic activity with in order to maintain glucose values. And then there's an area where the athlete can kind of go out into the dugout to check values and then ingest carbohydrate in a little bit more of a private place. For endurance sports, we've talked a little bit about these athletes need to be more careful about monitoring their values. They need to make sure they're maintaining hydration and have supplies for carbohydrate replacement. So either stashed along the route or someone who can, deliver things to them as needed when they're doing the long runs. Those that are running for longer periods greater than an hour need to adjust the rapid acting insulin in order to prevent hypoglycemic episodes during the run. And then when there's increased activity over an hour, they are at increased risk for hypoglycemia, and then need to make sure that they're participating in that replacement of carbohydrates during and after activity to prevent hypoglycemic rebound after running. There's less restrictions for those with type 2 diabetes in comparison to those with type 1. Triathlon events are ideal for participation in competition because they're in the transition zones from swimming to biking to running. Athletes can stop to use their devices, check their glucose values, and then replenish with carbohydrates as needed. They can also change their infusion rates in order to prevent hypoglycemia. And again, making sure that teammates are aware is important. They can also use the waterproof pumps, and they're not diving, below that level, so that everything is still within working order. So we've talked a little bit about that there's benefits for exercise for both individuals type 1 and type 2. Being aware of athletes' attitudes, managements, and goals are important in order to improve treatment. Knowing that a lot of treatment plans are more anecdotal rather than relied upon by research. And then knowing that there's different altitudes and training environments that can change glucose response and carbohydrate management, as well as insulin delivery. And then making sure that teammates and coaches are aware of activity plans in order to maintain safety for your athlete. And then there's some references. Does anybody have any questions? Okay.
This was helpful. Thank you.
Okay. Have a good day, guys.